diabetic population will be in Asia. And this is the data from an article published in World Journal of Diabetes in 2012. And currently, more than 30 million people live with diabetes in the Western Pacific region alone. Now going into a brief introduction on diabetes mellitus. Now diabetes mellitus has become a widespread epidemic, particularly because of increasing prevalence and incidence of type 2 diabetes mellitus. And diabetes mellitus represent a group of metabolic disorders in which there is impaired glucose utilization, including hyperglycemia. A defective or deficient insulin secretory response underlies glucose underutilization. Fat and protein metabolism are also affected in diabetes. Now going into the diagnosis of diabetes mellitus, the American Diabetic Association recommends any one of the following criteria for diagnosing diabetes mellitus. One is a glycated hemoglobin values of 6.5% or higher. 2. Fasting plasma glucose more than or equal to 126 mg per deciliter. 3. A 2-hour plasma glucose more than or equal to 200 mg per deciliter during an oral glucose tolerance test using 75 grams of glucose. And 4. Classic symptoms of hyperglycemia like polyuria, polydipsia, unexplained weight loss, etc. Now going into the classification of diabetes mellitus, as all of you know, diabetes mellitus is broadly divided into two categories. You have a type 1, that is insulin dependent diabetes mellitus, and type 2, that is non-insulin dependent diabetes mellitus. Now going into the type 1, that is insulin dependent diabetes mellitus, it is usually seen in people less than 20 years of age with normal weight. It accounts for 10 to 20% of diabetes mellitus, and here you have an absolute deficiency of insulin with decreased blood insulin levels, and this condition is characterized by autoimmune destruction of insulin producing beta cells of pancreas. Now going into the type 2, that is non-insulin dependent diabetes mellitus, usually seen in people about 30 years of age who are obese, and here there are no islet cell antibodies, and this condition is characterized by inability of muscle cells to respond to insulin properly, that is insulin resistance, and inadequate compensatory insulin secretion. Now going into the etiology of diabetes mellitus. Now genetic factors have been implicated as an etiological agent of diabetes mellitus. It accounts for 10% of causative factor, and it is said almost 36 genes has been identified as the etiological agent of diabetes. Now diabetes apart from this can also occur following pancreatic diseases, surgeries, infections, and ingestion of drugs or chemicals. And as all of you know, risk will increase with age, obesity, and physical inactivity. And type 2 diabetes mellitus more frequently seen in population with hypertension or dyslipidemia, or women with a previous history of gestational diabetes mellitus. Now going into the pathophysiology. Now in pathophysiology, it is important for us to understand a terminology which is known as insulin resistance. Now in type 2 diabetes mellitus, there is only a relative deficiency of insulin, and this insulin deficiency is not of a significant magnitude to explain the metabolic disturbances present in type 2 diabetes. So in that case, here there is an impairment of tissue response to insulin known as insulin resistance. Now insulin resistance is a complex phenomenon, and it is not restricted to diabetes syndrome alone. And insulin resistance is most marked in patients with obesity, but can also occur in non-obese type 2 diabetic patients and also in non-diabetic obese subjects. And the resistance to insulin present in patients with type 2 diabetes mellitus can occur as a result of defect at several levels in the action of insulin. Now before going into the mechanism of insulin resistance, it is important for us to understand the normal mechanism of action of insulin. Now following an appropriate stimulus, insulin is released from the beta cells of pancreas, and this insulin will bind to the specific receptors, insulin receptors present on the cell membrane. And this in turn leads to the translocation of glucose transporters. Now glucose transport into the skeletal muscle is accomplished via glucose transporter proteins, especially the glucose transporter 4, that is a GLUT4, which is the main isoform in muscle, and the effect of GLUT4 is mediated by both muscle contraction as well as by insulin. And under basal conditions, this GLUT4 resides intracellularly, and on stimulation, this GLUT4 is translocated to the cell membrane and it facilitates the uptake of glucose by the cell or the muscle. Now, what is the mechanism of insulin resistance? See, it can happen because of a number of reasons. One is because of a decrease in the number of insulin receptors. Now, for the proper action of insulin, the binding of insulin to insulin receptors is very important. Now, if there is a decrease in the number of insulin receptors, this binding won't be sufficient, and as a result, insulin won't be able to execute its actions. Now, reduced synthesis and or translocation of glucose transporter 4 in muscle and fat cells may also account for insulin resistance in obesity as well as in type 2 diabetes mellitus. And last but not the least, accumulation of intramuscular triglycerides and fatty acid metabolites may inhibit insulin signaling, thereby leading on to insulin resistance. Now, it is said that type 2 diabetes mellitus is associated with decrease in response to exogenous as well as endogenous insulin. That is, even if you give insulin supplements from outside, the response to insulin in a patient with type 2 diabetes mellitus will be poor because of the presence of insulin resistance. Now, going into my topic proper, that is exercise and diabetes. The triad of insulin, diet and exercise has been the basis of treatment for the past 60 years. And exercise is said to be the key element in the management of diabetes and delaying the development of type 2 diabetes mellitus. Now, goals of exercise. Now, these are the general goals of exercise which you all know. They improve the overall health and fitness, improves the cardiovascular endurance, improves strength, maintains an appropriate body fat composition. Apart from this, there are also some psychological gains like less stigmatization, improved self-confidence, socialization, and helps in attainment of a healthier lifestyle attitude. Now, what is important for us is the beneficial effects of exercise in type 2 diabetes mellitus. One is that it reduces the blood glucose level. Secondly, it preserves the beta cell function. Thirdly, it reduces the dependence on pharmacological therapy. And lastly, it also reduces the incidence of associated comorbidities. Now, how does exercise reduce the blood glucose level? It is through this following mechanism. Now, exercise decreases the insulin resistance present in diabetes by increasing the skeletal muscle sensitivity to insulin. Now, skeletal muscle accounts for 75 to 95% of whole body glucose disposal. And it is said that insulin sensitivity is greatly enhanced even after a single bout of exercise. Now, the time of onset of insulin sensitizing effect is unclear, as it may or may not be evident in the immediate post-exercise period. Now, increase in insulin-mediated whole body glucose uptake lasts for 12 to 48 hours after a single bout of exercise. And this increase in insulin-mediated whole body glucose uptake is observed in healthy as well as in insulin-resistant subjects. I told you this effect lasts only for about 48 hours. So this quick reversal of insulin sensitivity after exercise cessation indicates a need for a consistent exercise. And this is a major reason why exercise guidelines for type 2 diabetes mellitus suggest a maximum of 48 hours between exercise bouts. And the other mechanism by which exercise decreases the blood glucose level is that the contracting muscles, they increase the uptake of blood glucose. Now, the blood glucose levels are normally maintained by glucose production via liver glycogenolysis. It's a process by which the hepatic glycogen is broken down into glucose. Gluconeogenesis, again a process by which glucose is produced in the body from non-carbohydrate source, and mobilization of alternate fuels such as free fatty acids. Now, consistent exercise training increases the muscle mass and thereby increases the blood glucose uptake by increasing the surface area of the muscle. Now, early in exercise, glycogen provides the bulk of fuel for working muscle, and that is by the hepatic glycogenolysis, where the hepatic stored glycogen is broken down into glucose, and this glucose is utilized for providing energy. Now, as these glycogen stores become depleted, the muscles will increase the uptake and use of circulating blood glucose along with the free fatty acid released from adipose tissue. And intramuscular lipid stores are readily used during longer duration of activity. And this signifies the duration of exercise. Now, in a non-diabetic person performing moderate intensity exercise, the rise in peripheral glucose uptake is equal to hepatic glucose production. So, the blood glucose level in a non-diabetic person does not change except during prolonged glycogen depleting exercise. But in a type 2 diabetic patient performing the similar moderate intensity exercise, the blood glucose utilization by the muscles is usually more than the hepatic glucose production, and the blood glucose tends to decline. And this is termed as post-exercise hypoglycemia. Now, how does the contracting muscle increase the muscle glucose uptake? Now, the reason is as follows. Exercise leads to a low cellular energy state, and in such a state, the level of adenosine monophosphate is elevated, and this elevated adenosine monophosphate will increase the activity of an enzyme known as the adenosine monophosphate activated protein kinase, and this in turn will lead to the translocation of glucose transporters to the cell surface, and thus more glucose will be absorbed into the cell or into the muscle. Now, both aerobic and resistant exercise increases GLUT4 abundance and blood glucose uptake even in the presence of type 2 diabetes mellitus. Now, last we'll just see how exercise preserves beta cell function. I've already told you that in type 2 diabetes mellitus there is a insulin resistance, so there will be a relatively higher level of blood insulin, and this relatively higher level of blood insulin can exert a negative feedback effect on the insulin producing beta cells of pancreas, and this will lead to the premature loss of beta cell function. So exercise by reducing the insulin resistance enhances the activity of insulin and thus helps in preserving the beta cell function.